morning, good afternoon, and good evening to all speakers, chairs, and a wonderful audience in different parts of the world. Welcome back to another edition of very informative educational lecture for you. The speaker for the first session today webinar is our honored guest from United Kingdom, Professor Mario Teo. Professor Teo is a consultant neurosurgeon and honorary senior clinical lecturer at Bristol University of Clinical Neuroscience, not Bristol University Hospital, having completed a cerebrovascular and skull-based fellowship at Stanford University, California, USA. He has special interest in minimal invasive cranial and spinal surgery, a firm believer in personalized health care surgery with less tissue injury lead to minimal skull and quicker recovery. His clinical focus includes management of complex brain tumor, schwannoma, meningioma, craniopharyngioma, skull-based tumor, neurocutaneous disorder, and cerebrovascular pathologies such as Moyamoya disease, cerebral aneurysm, arteriovenous malformation, cavernoma, and hemangioma. He's noted author with numerous peer-reviewed publication, editorials, book chapters, and have advocated a collaborative clinical and scientific research at local, national, and international level. We are extremely honored to have him today as our speaker at our webinar. And today he'll be talking about advances in the management of Moyamoya disease. The speaker for the second session today is our honored guest from Brazil, Professor Erasmo Barros de Silva. Professor Silva is a coordinator of Neuro-Oncology Division at the Neurological Institute of Curitiba, Brazil. He's a member of Brazilian Neurosurgical Society, Society of Neuro-Oncology, and European Association of Neurosurgical Societies. We are extremely honored to have him as our speaker today, and he'll be talking about 5'ALA guide surgery in meningioma. The chair for the first session today is our distinguished and honorable senior faculty from China, Professor Zhu Bin. Professor Bin is a consultant neurosurgeon at the Department of Neurosurgery, Huashan Hospital, Shanghai, China. He is also a vice president of the Asian Congress of Neurological Surgeons. He's an executive editor of the Asian Journal of Neurosurgery. He is also a very proficient surgeon with a large number of bypass of Moyamoya in the world. He has a great supporter for online education activity and one of our main mentors who guide us in the ACNS webinar since the time of inception. We are extremely grateful to him for accepting our invitation to chair the session of Professor Mario Teo. The second chair for today's session is our honored guest from Cologne, Germany, Professor Cleopatra Karam-Lampaki. She is a professor in the Department of Neurosurgery at the Cologne Medical Center, Germany. She was previously worked in the Department of Neurosurgery in Medical University Mainz, Germany, under the leadership of Professor Axel Penensky. Her specialty is on minimal invasive neurosurgery, brain endoscopy, skull-based surgery via transcranial and endonasal and spine tumor surgery. Her recent scientific activity were about the development of new technique and technology associated strategy for minimal invasive neurosurgery, like intraoperative use of confocal laser endomicroscopy, combined microscopy, spectroscopic usability for the better differentiation between tumor and normal tissue, introduction of new fluorescent dye in neurosurgery in combination with technology development of new operative microscope. In 2014, she received a Mahalil Clinical Research Award from the AANS CNS section on tumor sponsored by National Brain Tumor Society in Boston, USA, for her advances in her confocal laser endomicroscopy in brain tumor surgery. We are extremely grateful to her for accepting our invitation to chair the session of Professor Erasmo Barros Silva. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both speakers and chairs and audiences to this online platform of ACNS webinar. A very warm welcome to our colleague in China. We are extremely thankful to Professor Zhu Bin for broadcasting this webinar on our WeChat channel. And with that introduction, I will hand over to Professor Zhu Bin, who just joined us. Professor.
Okay, great. Thank you, Dr. Liu. So tonight already there's 1,039 audience waiting for your presentations. So for the first speaker is Professor Teo. Welcome to our ACNS series.
Thank you. Pleasure is mine.
Yeah, now it's your time.
Okay. All right. So share my screen. Okay. Thank you for the invitation and the very kind introduction. So I'm going to be talking about the advances in Moyamoya management. And in fact, it can be a bit embarrassing to talk about this topic in front of Professor Zhu Bin, who's the world-renowned neurosurgeon on this topic. But I'll hopefully be able to share some of my learning pearls that I've gathered over the years. So Moyamoya disease is a very mysterious condition. It first described in Japan in the 1960s, so over 50 years ago. Mysteriously, the distal part of the ICA and the proximal MCA and ACA progressively stenosed and occluded off. And as a result, there's all these tiny little Moyamoya vessels formation to overcome the occlusion. And as a result of the tiny fragile vessels, they can bleed and lead to hemorrhage, or the occlusion itself might not lead to enough blood supply to the brain, leading to ischemia in patients. There has been several epidemiological studies on Moyamoya disease, and in the East, it's about 10 per million incidents. So therefore, for example, in China, with a population of 1.4 billion, you'll be looking at about 14,000 cases of Moyamoya disease per year. This, in fact, is a very recent paper that came out of China, published in Lancet in 2022, showing the incidence of different parts, different provinces in China on the incidence. The darker the color, the higher the incidence. But on average, it's about 10 per million. Now, in the West, it's a different story. In the West, it's 10 times less common. So therefore, for UK population, we'll be looking at about 50 to 60 cases per year with a population of 60 million. Now, what happened with Moyamoya disease? Natural history study would suggest that if untreated or treated with medical treatment only, long-term stroke risk is in the region of 8 to 10% per year. So for this talk, hopefully I'll be able to cover some of these questions. How best to manage this patient, number one. Number two, how can we help to reduce the long-term stroke risk? And if you were to perform bypasses for this patient, how can we reduce the surgical stroke risk? Taking into account of the surgical factors and patient factors. We also use machine learning and AI modeling to try to develop a perioperative bypass stroke risk predictive model. And we will propose the Stanford Berlin Moyamoya grading system that I'll show you later on. So first of all, with the management, there are so many different types of management options for Moyamoya disease. We know that the direct bypass is whereby a scalp artery is harvested and connected to a brain artery, typically the MCA directly. Or indirect bypass is whereby tissues are laid on top of the brain and allow for new vessel formation. And there are also the combined bypasses. Some people advocate that medical treatment is as good as surgical treatment because of the perceived too high risk of surgery. Now, with so many treatment options, what is the best option for the patient? There are different studies that has been carried out. The only RCT that tried to compare the treatment modality for hemorrhagic Moyamoya disease, published in Stroke in 2014, the JAM trial showed that conservative treatment has a higher stroke risk compared to surgical treatment. But there are some criticism about this study. It's a small study, 50 patients or so were included in both arms, and the p-value just about reached statistical significance. There are other systematic reviews and meta-analysis that has been performed. This is among the first from 2016 that tried to compare the different treatment option and the treatment efficacy. So since then, there has been at least 8 other systematic review and meta-analysis on this topic, looking at different aspects of the care for Moyamoya disease. Some look at only Moyamoya adults, some look at peds, and they included studies of different types. Some included comparative studies, some only longitudinal single arm study. So essentially what they try to do, they try to compare surgery versus conservative treatment, direct versus indirect. And these 2 studies try to compare direct versus indirect, or indirect versus combined, or combined versus direct. But they're all single comparison studies. Based on all this systematic review, the very common knowledge that we gathered is that ultimately surgery is better than conservative management, number one. Number two, direct bypass seem to be better than indirect bypass in reducing long-term stroke risk. But there are certainly limitations with each of these studies. Ultimately, a lot of these studies are sort of low quality single institution comparative studies with small-ish numbers. And the other thing with the development of technology nowadays, there is a technique called the network meta-analysis. So instead of comparing direct and combined, and you do them all manually, indirect and medical, and then direct versus indirect, and indirect versus combined, whereby there are 4 different modality treatments. You use this network analysis to combine them all and let the computer do all the analysis by doing all the various possibilities, permutation or combination of comparison. This was a new technique that has been developed. So one paper from Ding et al. Published in World Neurosurgery 2018 used this technique called the network meta-analysis, and they show that the direct bypass overall is far superior compared to indirect bypass, and they both are again superior to conservative treatment, and this is illustrated in this sort of staircase graph. Overall, the probability of reducing long-term stroke risk is said to be 99% with direct bypass, 1% for indirect bypass, and 0% for conservative treatment. So they concluded that direct bypass is far superior, followed by indirect bypass. Now, there is no overall reduction in mortality based on this study. So even though we reduce stroke risk recurrence for patients, but we don't change the overall survival. With regards to direct bypass versus indirect bypass, one of the criticisms is that direct bypass is a very high-risk procedure, highly technically demanding, therefore there will be higher stroke risk. This is a systematic review that we carried out. We looked at comparative studies only, and we included about 20 papers that compared direct and indirect bypasses. So you can see that the overall stroke risk is in the region of 6%. And if you compare the 2 treatment options, there is no differences in the perioperative stroke risk. This is for the adult population. For the pediatric population, only smaller numbers of studies are able to extract information from. The perioperative stroke risk is about 5%. And in terms of the risk comparing direct bypass and indirect bypasses, there is no statistically significant difference when you compare the odds ratio, even though it does look like perhaps there's a slightly higher risk of direct bypasses in causing perioperative stroke risk in pediatric population. So overall, based on all this information that we have in the literature, we would conclude that direct bypass, if possible, will be far superior, and therefore we should be aiming to offer this to our patient in order to reduce their long-term stroke risk. Now, what about the technical factors to be taken into account for doing direct bypasses? It's a very technically demanding surgery, and as many of us would know, these vessels are very tiny. Therefore, you will need a lot of practice to do this sort of surgery. So I just prepared a little video here. This is the way we do it: Doppler out the vessel, horizontal positioning of the head positioning, and then when we harvest the bypass graft, very careful dissection, as the vessel is very superficial typically, and we take all the care we can in order to safely harvest the STA vessel. So once we are able to get the STA vessel safely off the temporalis fascia, then we would then divide the temporalis muscle, protecting the STA graft at all time. Next step is about harvesting doing the bone flap and making sure that we have a nice enough craniotomy. Just before opening the dura, we will prepare the distal vessel, making sure that it's all exposed. And we also prepare the proximal vessel to allow temporary clip application. So after dural opening, ensure good hemostasis. These vessels are normally about 1 millimeter. Once we have identified our recipient site, carefully dissect the P arachnoid away from the MCA vessel. So just before we apply temporary clips, typically we would then get temperature for the patient down to about 35 degrees, and then we will bring the blood pressure up by about 10 to 20% from the baseline. And then we also give thiopentone for burst suppression just before the temporary clip application to the MCA vessel. Now the SDA graft is flushed with heparinized saline, and we fish mouth the vessel. So now temporary clip application. So followed by the arteriotomy. So I prefer the interrupted suture techniques. These are 10-0 nylon vessels. This is 10-0 nylon suture material. So you can see we also apply some dye in order to see the vessel wall and confirm the bypass graft patency using ICG. So at every step during the closure, we also make sure that we use Doppler to check that the bypass graft is patent, the STAN. So when we close, I thin down the inner wall of the bone flap in order to reduce the pressure on the bypass graft. So this is a little editorial that we write comparing direct and indirect bypasses. It does provide immediate and significant improvement in cerebral blood flow and cause more symptomatic improvement for the patients, longer stroke-free survival, less recurrent hemorrhagic risk, and more superior in restoring the cerebrovascular reserve based on the SPEC studies that we have done. Based on angiographic studies, there's also better external angiographic revascularization and lower rate of needing repeat revascularization in the future. But it is technically more challenging. And for some vessels, if it is less than 1 millimeter, especially in very young children, it can be very challenging and difficult. But in the pediatric population, we know that the indirect bypasses, because of the brain angioplasticity, they do form a very good collateralization. Therefore, we wouldn't hesitate if you have to perform indirect for the young population. So those are the technical aspects of making sure that we perform a good surgery, every steps, good lot of practice, and careful anastomosis, and checking the papers, the patency of the bypass graft at the end using ICG. Next step is about how can we reduce perioperative stroke risk. Now, Suzuki stage that was described over 50 years ago was a radiological description of the different stages of Moyamoya disease. Stage 1 is when there is a little bit of a narrowing of the ICA, through to stage 6, where the IC is completely occluded off, and patients relying mainly on the extracranial to intracranial spontaneous collateralization. But this grading system doesn't really give us any bearings on surgical morbidity, on patients' clinical symptomatology, or the severity of the patient's diseases. And as a result, we think there must be a need to have a newer grading system for Moyamoya disease. Now, this work is mainly looking at how can we have a grading system to help grade perioperative stroke risk. Now, we define major strokes as a DWI, positive strokes, or hemorrhage after bypass that leads to change in the patient's MRS. So there are 3 parts to this study. First of all, we use over 1,000 bypasses from 1991 to 2014. These are all patients from Stanford University who had bypass surgery. And then on the validation cohort, a cohort from 2015 to 2018, to see how good the model that's developed from the initial cohort and whether it will be validated in the second cohort. And thirdly, we use a predictive modeling, machine learning, artificial intelligence to see if we can come up with a predictive model for designing a perioperative bypass stroke risk. So Berlin grading system was described over 5 years ago, initially to correlate with patient symptomatology. And as you can see here, they take into account 3 factors: the angiographic findings, the MRI finding, and the cerebrovascular reserve finding. So for the angiographic finding, they simplified it into 3 grades. When there is sternal occlusion and Moyamoya vessel, there's 1 point. When there is spontaneous intracranial to intracranial collateralization, there's 2 points, meaning there's collateralization from PCA to ACA or MCA. And I'll show you some figures later on. And there will be 3 points if there is spontaneous extracranial to intracranial collateralization, meaning from either middle meningeal artery or the occipital artery. With the MRI finding, any old sign of ischemia or hemorrhage or atrophy will get 1 point. And cerebrovascular reserve study, if there is still phenomenon whereby the cerebral blood flow reduce on diamox challenge, and they'll be given 2 points. So they show that this Berlin grading system, the higher the grade, then the higher the chance of patients having symptoms with Moyamoya disease. Now, with this work that we do from Stanford, over 1,000 bypasses over 15 years, we found 52 major strokes, so that's about 7% stroke risk per patient. And the risk of bypass after first bypass is about 5% stroke risk. After second bypass is 2.6%. This is a demographic illustration of the number of bypasses being performed per year in Stanford. So since 2006, over 100 bypasses per year. So the maroon color is for the adult population, purple color for the pediatric population. Of all the risk factors that we can identify from all the various studies and literatures, and also based on our understanding that could be associated with the increased postoperative stroke risk, we analyze them in this regression. So we look at patients' demographics, their age, the past history, their presentation, the Suzuki staging, the angiographic score, the modified MRI score, and a hemodynamic reserve score. So this is where I was explaining angiographic score of 1 point is where there is sternal occlusion. When there is spontaneous PCA to MCA collateralization, they got 2 points, or PCA to ACA collateralization, there's 2 points. And if there is spontaneous extracranial to intracranial collateralization, there'll be 3 points assigned on the DSA score. For the hemodynamic reserve study, this is the xenon SPECT scan. Red means increase in blood flow after acetazolamide. So normal response should be all increased. But in patients with Moyamoya disease, we know that sometimes there might not be any increase, which is white, or the blood flow could even decrease, meaning steal phenomenon, whereby the blood is stolen away by other hemisphere. So in this Berlin's grade, they will assign 2 points for the steal phenomenon. But there are some patients which did not quite exhibit the steal phenomenon, but they do not augment. So we then make a modification to the Berlin grade, and we add another point for impaired augmentation, whereby even if they don't have steal phenomenon, but because they do not augment properly, they will have a point for the hemodynamic reserve score. And if there is a new DWI positive infarction, there will be 2 points associated on the new grading system. We believe that the DWI positive infarct, which happened within 4 weeks of surgery, does give rise to higher stroke risk. So this is the age distribution of all the patients. There's 2 peaks between 30 to 40 and the second peak in the pediatric population, 6 to 10. And you can see the more female population, these are mostly Caucasian. And in the pediatric population, 75% of the patients had direct bypasses. And in the adult population, 96% of the patients had direct bypasses. So when we look at all the univariate analysis on the stroke risk, comparing the age categories, the sex, the ethnicity, family history, and that's the p-value and the stroke risk. We can see for age, older the patient, the higher the stroke risk. So for less than 18 years old, stroke risk is 2%. Over 60 years old, stroke risk as high as 20%. What other factors are significant? So we can see ischemic presentation, patient who presented with stroke, higher stroke risk, 7.6%. Diabetes history, higher stroke risk. Hyperlipidemia, again, higher stroke risk. Angiographic score, the higher the score, the higher the stroke risk. So score of 3, meaning spontaneous ECIC collateralization, stroke risk of 15% compared to sternal occlusion, supposedly 0 stroke risk. MRI score, so if patient has a new infarct, meaning DWI positive infarct within 4 weeks of the bypass surgery, stroke risk is about nearly 40%. Hemodynamic reserve score, if there is still phenomenon, 22% stroke risk. Impaired augmentation, 6% stroke risk. And these are all statistically significant. Types of bypasses, you can see direct and indirect, it doesn't quite reach statistical significance. One thing that is to be discussed is that some of this does not take into account of confounding factors, therefore multivariate regression analysis was performed, and only 4 factors come back with statistically significant p-value, which are the age cohort, angiographic score, modified MRI score, and hemodynamic reserve score. So all the other factors, even though on the univariate analysis showed significant p-value associating with the post-op stroke risk, are no longer significant. So therefore, based on these 4 factors, the age, the angiographic score, the MRI score, and the hemodynamic score, we come up with this Stanford Berlin Moyamoya grading system, and we assign scores to different groups with the age categories, 1 point for less than 18 years old, 4 points if you're over 60 years old. And we use all these points that's designed, and we create an ROC curve. And it showed that there is a very good correlation between this model and the post-operative stroke risk. The area under the curve of 0.85 shows good correlation. And this is a probability curve that shows that the higher the grade, then the higher the stroke risk. So blues are patients with strokes. So up to 6 points on the Stanford Berlin Moyamoya grade, stroke risk is very low, less than 5%. Whereas the score of 7 and 8, you can see the stroke risk is in the region of up to 20%. Score above 9, stroke risk could be above 20%. So this is considered high risk group. Would this model be applicable in a different cohort? We tried to validate this in a different patient population from 2015 to 2018, and we found very similar results. So the area under the curve is 0.76 again, show moderate correlation. And as you can see, the higher the score, the higher the risk of strokes. So up to 6, stroke risk is considered low, 7 and 8 will be considered moderate risk, and more than 9 will be considered high. So when we use the machine learning predictive modeling, we combined all the patients, which consists of over 1,000 patients, with 78 event rate. We split them into the train set and the test set in order to allow the 30-day stroke events to be allocated proportionately. The very clever statisticians from Stanford University and Johns Hopkins helped me with this work. Using a machine learning, they were able to normalize the predictors and do data imputation and dimensionality reduction using various regression models. So we found that the gradient boosting machine learning models work best in this model. So essentially what it does is with every successive training of the model, it can increase the accuracy and the performance of the model that we created. And with this gradient boosting machine model, we were able to show that the 4 factors that are associated with the post-op stroke risk are the MRI score, the hemodynamic score, the patient's age, and the angiographic score. And taking those 4 factors into account, and we apply that into the testing set, the model can achieve an accuracy of 93%. So that's pretty good, considering that it is a preliminary work that we have done. So therefore, we find that the Stanford Berlin Moyamoya grading system could be a very useful tool for us in terms of helping for stratifying patients' stroke risk, and also for part of the counseling process, and even helping us with our decision making. For example, if patient had a DWI positive infarction, within 4 weeks, we don't tend to offer them bypass surgery. We let them cool down and wait before we offer surgery at a more delayed fashion after 4 weeks. And we find that that seemed to reduce the bypass stroke risk. So despite all that we do, there are still some cases whereby they would need repeat revascularization because of ongoing symptoms. And the reason could be because of bypass graft that do not quite take. For example, in this case, in the indirect graft that only shows very little collateralization. So then the patient had a direct bypass. And with direct bypasses, the Moyamoya vessels can obliterate, and this in turn can reduce long-term hemorrhagic stroke risk. Now, in some cases, the ST vessels might not be available because it has been used in previous surgery. So what are the salvage strategies that could be available? Occipital artery could be another option. It's a more technically demanding harvest and technically more challenging surgery to anastomose, but it's doable. And the other option is to use omentum. This has been used in about 20 cases. This was back in Stanford, and we were able to get pediatric surgeon to harvest the omental pedicle graft, and the gastroduodenal artery can be brought all the way up to perfuse the brain. You can see with an example here, the omental flap can perfuse the part of the brain which doesn't quite get all the collateralization that's required. So this is another salvage strategy that can be used in very few selective number of cases. And based on our understanding on the studies that we have done ourselves, only very few patients, less than 5%, needed repeat revascularization if they had previous direct bypasses. Patients who had previous indirect bypasses, some of them came to Stanford and had repeat revascularization, and that was published in different papers. So long term, what happened with all these patients after we have done bypasses for them? This is a questionnaire that was sent out, and we get over 90% of patients who return the questionnaire in the nearly 800 patients. And we found that in the long term, up to 25 years of follow-up, the headaches improve in over 80% of them. A lot of them remain employed. Some of them are doctors and lawyers. Some of them have gone on to go to university if they had Moyamoya disease diagnosed when they were very young. A lot of them are self-caring and independently living, and over 80% of them has excellent long-term outcome. So essentially, this is telling us that over 80% of patients are actually very, very good, meaning that they live a normal lifestyle after bypass surgery and no longer have any problem. And looking at the MRS grading system, with the last follow-up, a lot of them are in MRS 0 and 1. So over 80% of them. With the recurrent stroke risk with a follow-up of up to 25 years, the risk would be higher for patients who are older, which kind of makes sense because older patients, after 10, 15 years, if they're 60 years old when they get diagnosed with Moyamoya disease, despite bypass surgery, after another 10, 15 years, they could be prone to developing atherosclerotic strokes. Whereas for the pediatric population, the younger population, you can see that the bypass would help them prevent recurrent strokes for at least 15 years before they're at a higher risk of getting strokes again. Based on all these studies that we have done, it does look like the bypasses, especially direct bypasses, is very, very robust and efficient in helping patients with Moyamoya disease, in reducing their long-term stroke risk and restoring their functionality. So overall, I hope that I have shown that with the best management, based on our understanding of Moyamoya disease so far, we still prefer direct bypass or combined bypass. In a lot of these studies, the efficacy of direct bypass and combined bypass is classed together because they're supposedly having similar efficacy. And if you think about it, direct bypass is also a type of combined bypass because you have a live vessel that's connected to an MCA vessel. And with the soft tissue surrounding the direct bypass graft itself, over time, it will form indirect collateralization. So therefore, the effect of direct bypass is essentially the same as combined bypasses. So with the network analysis that was performed by one paper, they showed that direct bypass is far superior compared to indirect, compared to conservative treatment. Now, with the limitation, obviously, with any studies that we include, the study quality is only as good as the results of the raw data. And as we know, the raw data, there's only one RCTs in the Moyamoya disease, and everything else, they're all institutional comparative studies, so they are not as robust as we like in terms of the quality of the data. But sufficient to say that based on what we have, based on our understanding on the management of Moyamoya disease, direct bypass would offer a superior result. Now, in terms of strategies to reduce stroke risk, the surgical factors to be taken into account obviously include very good surgical techniques with a lot of practice in anastomosing a millimeter vessel prior to doing it in patients. So I remember when we did it in Stanford, we did a lot of practice in mice and the rats because they have similar caliber vessels before you would do it in human being in order to ensure we can achieve bypass patency. Other surgical factors taken into account would include the good anastomosis technique and ensure ICG to confirm bypass patency, and during the closing stage at every step of the closure, making sure that the Doppler signal is still intact. And like I said, I would drill down the inner table of the craniotomy in order to reduce the amount of mass effect on the bypass graft itself, and also create like a surgical tunnel for the vessel to go through without being strangulated. So for the closure itself, the muscle closure loosely around the bypass graft, and the scalp closure multi-layer because the dura are not closed, and you just do meticulous scalp closure in order to reduce the risk of wound breakdown. And in terms of patient factors to reduce stroke risk, these are the factors that we have highlighted based on the studies that I've shown you in the multivariate regression analysis. And the 4 factors: age factors, angiographic finding, modified MRI finding, and the hemodynamic reserve finding. So we believe that this scoring system could help us stratify patients into different groups. So if they score 6 points or less, then the stroke risk will be considered very low, less than 5%. If they score 7 and 8, moderate stroke risk in the region of up to 20% stroke risk. If they score 9 points or higher, So the stroke risk would be 20% or higher. So that would be considered high bypass stroke risk in our mind. And therefore, it would help with our patients' discussion and counseling process. Now, with this proposed Stanford Berlin Moyamoya grading system, it is a pretty provisional work, and definitely we need bigger cohort in order to validate such a work. And in fact, when we look at population in Asia, whereby the incidence of Moyamoya disease is far higher, so there will be hopefully a lot more patients that we could try out this model to see if it would fit in the other population. And hopefully we can translate it into a wider clinical use in the future by having some worldwide collaboration work. With the AI machine learning stroke modeling, it needs more fine tuning, and hopefully again, if you can get more collaboration from centers across in Asia, including China, Japan, and Korea, then once we get more numbers, we'll be able to increase the accuracy of the stroke model. Thank you.
Okay, great. Thank you, Professor Teoh. So unfortunately, we couldn't use Dimox. We don't have the transvenous Dimox in China. So we yeah, that's a pity. So we couldn't use the Berlin grade system because I think it's important, but different country have different conditions, and I think different Moyamoya disease actually it's very have a very wide spectrum of the different hemodynamic conditions.
Correct.
Yeah. So different neurosurgeons have a different opinion on their decision making. Yeah, I'm a hybrid neurosurgeon, both doing the interventional treatment and the open surgery, and I now have over 9,000 bypass experience. Most of them is Moyamoya disease or Moyamoya syndromes. So in my opinion, the most important thing is the recipient network, which is means MCA network. The integrity of the MCA network is very important in making the decision for direct bypass or indirect bypass. Yeah, I write a chapter on Peter new book about the surgical technique about the Moyamoya. Yeah, and I think the integrity of the MCA network is very important in decision making, and the pressure gradients of the MCA have two types. One type is still keeps the physiological direction from proximal to distal, which means from M1, M2, then M4. But we have another type of the pressure gradients. It's reversed comparing to the physiological direction. Actually, it comes from ACA branch or PCA branch. Then the M2 segment was the lowest pressure. So the pressure gradients is reversed. So this kind of condition is also very important in making the direction of the bypass. And we also have some different view about the spontaneous stomas. I noticed that you mentioned the spontaneous stoma come from middle meningeal artery as a risk factor.
As a risk factor, yeah, that's right.
Yeah. Actually, I think this is an advantage for the patient. This kind of patient means have a greater potential to form the indirect bypass. So this kind of patient, we will do the definitely we will do the combined approach which in this kind of patients, actually the spontaneous stoma would form very well because the cortex already have the ischemic condition comparing to the muscle. Yeah. So this can induce indirect bypass. Yeah.
Totally. I mean, you have the most experience on Moyamoya disease compared to anyone else in the world. I'm sure what you say is very true. Now, with regards to the Diamox, is it because of a legislation issue that it's not allowed to be used in China? I mean, what's the difficulty with the Diamox?
No, we don't have the. We actually, about 20 years ago, we have the Diamox through oral, but not with the Diamox with the transvenous dose. Yeah.
And
so
was it because
we never use that.
Was it because
we don't
of the
have
risk?
This. No, we don't have it on market, on Chinese market. Yeah.
And
yeah.
Do you believe that there is a need for it? Like if there is a, because if you look at the Moyamoya population in China, it's so big.
Yeah.
You know.
Yeah.
And if you can help quantify
I
the
think it's
hemodynamics in patients.
Yes. I think so, but we don't have this Diamox transvenous dose.
Okay.
So we never use it.
Okay.
Yeah.
Yes.
But we still can analyze the DSA. I think we have more experience in analyze the DSA results. Yeah, and we also use it 3D or now we can use some 4D DSA to make the decision where should be the recipient artery and where should be the donor artery. Yeah.
Oh, interesting. 3D with the
4D, actually, it's 4D. Yeah.
Those are all advancements, I'm sure. Yes.
Yeah.
Anything that help with the first of all reduce the post-op stroke risk, and number two to improve the collateralization would be very helpful. You're right. I believe the direction of the MCA flows, they are not all the same. Like you say, some of them you Doppler them and the signals are very poor, and some of them they've got like fairly robust signal already. Then you're right. The strategy should be tailored according to individual circumstances.
Yes. So I always insist that tailor the surgical treatment for the different patient. Yeah. Okay, great. Thank you.
Thank you.
Very nice presentation.
Thank you.
Professor Teo, can I ask some question, Professor?
Yeah, for sure. Thank you.
Yeah. I just wanted to find out from you, after you did the Stanford Berlin Moyamoya so-called classification. So with that, do you have any group of patients that you would never operate on them because of high risk of stroke? My second question, Professor, regarding the surgery, direct bypass, how often or what are the incidents that you could not find recipient artery in your surgery, and what do you think that a most probable cause, and what are the pre-op investigation that can help you to reduce the chance for not be able to find the recipient artery? My last question, Professor, you did mention that all direct bypass is also indirect bypass because of surgery itself. So in your opinion, for direct bypass, do you prefer small craniotomy or big craniotomy? Thank you, Professor.
So the first question is about the Moyamoya grading. Is there any population that I would not operate on? So yes, there will be. So like, for example, if they're old, if they're like 65 and they get acute strokes, again, I think the stroke risk is not worth it, for this group patient, because their natural history would probably suggest that the long-term stroke risk would be comparable to your bypass stroke risk. Therefore, it's acceptable for patients to go for the conservative management route. The second thing is the DWI stroke. So if they develop a DWI infarct, for example, and typically in the past, the instinct is to say, oh, well, patient has a stroke, so we need to do a bypass quickly for them in order to improve the cerebral blood flow. But that's counterintuitive because we find that, in fact, what you do is you have a higher stroke risk if you do the bypass at a very acute interval. And as a result of what we learned from Stanford experience anyway, that we let this patient cool down for about 4 weeks before we go for the surgery. So we're not saying that we don't offer them surgery, but we're just offering them at a different setting, you know, in a more delayed manner. The second thing is about, would we ever not find a recipient vessel? So that is quite closely related to your third question, because your third question is about the size of the craniotomy. Now, when I do bypasses, I normally harvest a graft of about 8 centimeter, and the craniotomy is about 5 centimeter diameter. So as a result, it's kind of a big-ish craniotomy. And I do know there are people who do very tailored, like small craniotomy. They use Brain Lab or Stealth, and they say, oh, this is the recipient vessel. So they're gonna make like a little tiny 1.5 centimeter craniotomy in order to do the connection. And that is, in my mind, not ideal because, like I say, direct bypass also promote a lot of indirect collateralization. Therefore, the 5 centimeter craniotomy, you usually will be able to find a recipient vessel. The only time when you do not find one is when the vessels are very small. Like for example, patients are very young. So if the patients, when you harvest the STA, you already know that these vessels are less than 1 millimeter. And generally, the vessels, even intracranial vessels, will be less than 1 millimeter anyway. And as a result, it's harder in those cases. So down to 0.8 of a millimeter, we can anastomose quite comfortably. 0.8 or lower, I'm sure maybe Professor Xubing can do it, but in my hands, I find that it's too challenging. And there are people who claim that they can anastomose down to 0.6 millimeter of a vessel. But you will then sometimes wonder, yes, even if you have very good technique, down to 0.6 millimeter, even though you can ensure graft patency immediately post-op, would it really lead to long-term patency, you know? Because a lot of the time, once the indirect take over, then the direct graft tends to obliterate off because it depends on the demand. If the brain demand is high, they will try to absorb as much blood as possible based on whatever avenue they can get the blood from. And the indirect grafts in the longer term, when you look at angiographic finding, you find that with your direct graft, it does give some blood supply, but there will be some supplementary indirect supply for sure.
Thank you, Professor. Professor Zubin, you want to give a concluding remark, Professor?
Yes, actually, I agree with Professor Teo. We wait 6 weeks after the acute stroke. Yeah, just like you mentioned, it's cool down progress. Yeah, and my smallest stoma recipient artery is around 0.4 millimeter. I think if it's even smaller, actually the blood volume would be very poor. So that's the smallest one I ever did, and the follow-up is quite good because I think the MCA network's integrity is a very important parameter for our direct bypass. So, Dr. Liu, you should remember I presented the keyhole bypass. The most important thing is we analyze the MCA's integrity before the surgery. Yeah, if the MCA integrity is quite good, we will do the keyhole bypass because we can guarantee the blood flow very well.
Thank you, Professor Zubin and Professor Teo for a very nice presentation, nice discussion. I think it's time to move on to the next speaker. Let me call upon Professor Cleopatra to introduce our next speaker. Professor.
So the next speaker is coming from Brazil. It's Professor Erasmo Barros Silva. and he will speak about 5'ALA guided surgery for meningioma. Please welcome.
Good morning, everyone. Good morning to Curitiba. To you all, I think it's afternoon. So I'm very honored by Dr. Raj's invitation to this presentation, and it's an honor to talk to you today. So the theme is 5'ALA fluorescence-guided surgery and its application for meningiomas, a very vibrant and very controversial, still controversial theme. We discuss about recent literature and about the experience we had here in Brazil from 2015 until now with our series of cases here at Neurological Institute of Curitiba. So meningiomas are the second most common primary tumors affecting the central nervous system, accounting for more than 35% of the primary brain tumors in adults. The vast majority of meningiomas are slow growing, so they still grow very slow. Still a benign tumor out of certain subtypes are more aggressive than others. So mostly important, benign does not mean then that they are without risk. So it's a very important consideration. Depending on its size and location, a benign meningioma can cause significant problems to the patient, become a possible life-threatening neurological impairment, and be extremely difficult to treat. According to the location, we can have a very challenging surgery. It originates from the dural covering of the brain. Meningiomas are often classified based on the site of origin, the involvement of adjacent tissues, especially venous sinus, bone, brain, and nerves, and histological grade. The majority of meningiomas often fall into histopathological classification of the World Health Organization, grade 1, whereas grade 1 is still the majority and the benign lesion, whereas atypical meningiomas are grade 2, and malignant or anaplastic meningiomas are grade 3. Occurs less frequently and constitute about 5 to 10,000% of all meningiomas. So these are the classical Simpson grade classification. The Simpson grade of meningioma resection was described about 1957 and correlates the degree of surgical resection with symptomatic recurrence. To further minimize the recurrence, Dr. Almefti in 1993 proposed a classification, a modification for the Simpson grade, an additional dural margin removal of about 2 centimeters around the tumor. He was intending to upgrade this, reduce this recurrence rate, who is still allowing even at the 60s. So the treatment, the surgical treatment, is most effective when gross total resection is achieved, aiming to remove the complete tumor while preserving neurological function. It's very important to notice that. Incomplete resection is a major risk factor for recurrence. So the Simpson grade aims to define the recurrence rate. The chances of safe gross total resection without compromising neurological outcome may decrease due to location, such as, for example, the cerebellopontine angle, cavernous sinus, very challenging locations, invasion of dural and or bone, and involvement of neurovascular structures. Incompletely resected tumors and high-grade lesions, the grade 2 or grade 3, the anaplastic meningiomas, are frequently additionally treated with fractionated radiotherapy or stereotactic radiosurgery. So we often need radiation for this case in the high grades lesions. When we talk about the 5'ALA, so it was introduced first time in 1948 by Moore, fluorescein. It was applied to visualize brain tumors, and later 5-aminolevulinic acid, or 5'ALA, has been implemented mainly in high-grade glioma surgery. So Dr. Stummer described the first series in about 1998, improving overall survival and progression-free survival in these patients. So the results comparing tumor removal with and without 5'ALA came from Dr. Stummer's. He have a phase 3 study in 2006. Okay, he published where we have we have a 55% of tumor removal in the 5'ALA group versus the 35% in the control. So we have improvement of the tumor removal and consequently the improvement of the overall survival of these patients. In the last 2 decades, so we have this technique with 5'ALA has been safely applied in a range of different types of central nervous system tumors. For example, meningiomas, hemangioblastomas, metastatic brain tumors, and also intracranial meningiomas. And at the world, we have a 5'ALA approved in Europe, Australia, Canada, Asia, in the United States. The FDA approved in 2018. In Brazil, we have approval since 2004. So its indications still be studied till now. So the 5-aminolevulinic acid is an indirect fluorophore and a natural biochemical progenitor of hemoglobin. So it was administered orally. The patient takes with water the current, and 5'ALA is reabsorbed through the upper intestine into the blood, passing the blood-brain barriers. It provokes the synthesis of protoporphyrin 9, and it's considered an endogenous photosensitizer. Excited with the blue fluorescence excitation light, protoporphyrin 9 emits the red light energy, which is visible to the human eye. So you can see when we put the lights, when change the light, the white for the blue, we can see the protoporphyrin in red. This filter is scoped to the surgical microscope, so we can change between white and blue light anytime during surgery. So it's a very easy to deal with the filters. So basically, we can distinguish 3 different surgical sites, 2 different surgical zones. So under this blue fluorescent light, red zone, full of malignant cells, blue zone without tumor infiltration, and pink or poor fluorescent zones, possibly with less cells concentration. So although 5'ALA accumulates very selective in malignant tumors, this process is not entirely tumor specific as non-malignant tissues. Brain parenchyma, subependymal zone, and choroid plexus, for example, also shows protoporphyrin 9 accumulation. We still not fully understand why it happens, but it's a matter of cell quantity, not quality. So we have a more quantity of malignant or different cells, and not the quality of the cells. So we can see in this image the practical image, the surgical image of 5'ALA. So this is what we can see during surgery, changing the filter. In this example, we can see for a case of a high-grade glioma, glioblastoma removal. The tumor limits were determined with the aid of fluorescence. So the last image is at the left, or at the right, we can show tumor cavity without red or pink spots. You can see in the lower column, in the lower line, we can see before total removal and after the removal. So for convention here at the INC, we call a total removal of 5'ALA a positive tissue, the red zone, as a 5'ALA free removal. So if we remove all the captants, the fluorescent region, we call it a 5'ALA free removal. So if we have the whole surgical field in blue at the end of surgery, we can consider with this kind of consideration. So the administration, and I said earlier, it's a very easy, an oral dose of 20 milligrams per kilograms of 5'ALA is administered 3 hours before surgery, per surgery. according to standardized protocols. After the administration, the patient is guarded from direct light for about 24 hours to avoid porphyria-like skin reactions. Beside this, the preoperative care remains unchanged. We didn't change anything about our care. So we have a few articles about our experience. We're using 5'ALA since December 2015 in a total of more than 4,000 cases until now. About 60 to 65% of our cases are of high-grade gliomas, but also for other CNS tumors. And even a typical diagnosis such as cystic fibrosis, radionecrosis, inflammatory diseases. So it's often any case of tumor we can use 5'ALA at our institution. So it's still an off-label tool, but as an academic institution, we try to study and maybe extend the indications of 5'ALA fluorescence. So in meningiomas, they still have a high 5'ALA positive fluorescence, higher than metastasis. Metastasis, it's about a 50 to 70% case of positive fluorescence. It may change in meningiomas may change from 77 to 96%, and the tumors often have a homogeneous fluorescence. It may be especially useful for tumor borders and adjacent infiltration, such as dura mater or even bone invasion or vessels invasions. So we always ask, is it positive? That's our question, to respond with yes or no. If we can remove the 5'ALA positive border or limits without risk of neurological impairment, it's very important and basic. We go on to obtain a blue surgical field, what we call the 5'ALA free removal, as I said earlier. We can also suspect a right intratumoral fluorescence homogeneity and a 5'ALA positiveness in any grade. So there is no correlation between fluorescence and mitotic index, such as MIB1 and Ki-67. We still don't understand fully this. So sensitivity and specificity rates may vary in literature, but are often high. So we have a tool, and we didn't comprehend it very well, but we can see it at the practical. We can stand these indications in the practical. So about meningiomas, we should often ask, so why? So now we can focus on these two questions to discuss the indications and applicability of the 5'ALA fluorescence for meningioma surgery. That I think it's very important. Why use this tool? If we have the 60 years old Simpson classification as a canonic reference for tumor removal, how can we improve meningioma surgery with 5'ALA? When should we use 5'ALA meningioma surgery as a safe, reliable, and ethical tool in synergy with the armament we have? We have a lot of tools, navigation, electrophysiological monitoring, etc. So we have this, we can see in the literature, these two revisions from 2015 and 2019 reviews evaluated the literature and summarized the intraoperative use of 5'ALA, aiming to determine benefits of fluorescence guidance during meningioma surgery and striving for radical resection, a gross total resection. The majority of included studies are case reports or series with low level of evidence. Only a few reports, larger patient cohorts. Most studies are retrospective, and no randomized controlled trials have been reported. So what they show, and short-term outcomes were mostly positive. So in the practical, we see these outcomes. However, most studies lack long-term follow-up, which are essential for the evaluation of fluorescent techniques. Out of these issues, we can also see the 5'ALA might aid surgical resection in selected cases through detection of meningioma remnants or invasion, or by aiding in safe vascular sacrifice. That's very, very important. In our series, we have about 49 cases. Tomorrow, the 50 case will be tomorrow, of meningioma treated with 5'ALA, 44 grade 1 benign tumors. Of all cases, only one case had a negative fluorescence. So our tax of positiveness, it's about 98%. In 5 cases, we had spots between red, pink, the pink, the pore, we can call the pore fluorescence, and even blue zones. 2 cases were recurrence operation, another 2 cases had the irradiation before, and just 1 case was primary, you know, of this case with heterogeneous zones. So we can now see the first illustrative case. I'll show the video. It's an olfactory groove meningioma. The first small olfactory groove meningioma. You can see this. The side in the right, in left side, we can see the small lesion, and at the left side, at the right side, we can see the postoperative. So let's play. In this case, a right frontal lateral craniotomy was performed. Dura was opened. This sylvian fissure was drained laterally. You can see the falx, and you can see the olfactory nerve. The tumor was in the midline between the 2 nerves. We can see now the tumor. You can see the positive fluorescence now. So the tumor was dissected, the implantation base was coagulated. It's very important. It's crucial for the surgery. And the tumor was removed. So there's any change in the technique, just the change of the light in special parts of the surgery. You can see the skull base, the olfactory groove, more coagulation at the dural basis, and we're almost at the final inspection of the 5'ALA. More coagulation to the falx. And we can cut any suspicious dura, and always avoid the risk of recurrence. That's very important. Okay, we can see a final inspection with the blue light, and it's important we can very soon not see the normal bone in green under the blue fluorescence. One last time, see the bone. It's like a green, different from the infiltrated bone where we can be in red. Okay, so we have another illustrative case. The second case is of a left sylvian meningioma, possible radio-associated, not radio-induced. It's not a very good term, so radio-associated, I think it's the correct. For this video, we have the narration of Dr. Hamza, one of our residents, our fellow residents in the audio. So let me hear from him. The video's a bit too long, so I'll skip some parts. Let's see if you can hear. Are you hearing?
No, there's no sound.
No? Ah, okay. No problem. I'll skip to the video. Sorry. So it's a case of a child star patient with 45 years old, male, with story of medulloblastoma. We have a gross total resection, irradiation, chemotherapy, and we had a possible radio-associated left frontal meningioma. I will skip to the surgery. There's no deficits. The findings, you can see the image here in a left sylvian fissure. Okay, that shows the surgery. So we have the patient positioning, so the surgical planning. We have the planning of the craniotomy with a frontal temporal craniotomy, left frontal temporal craniotomy, the left, with the aid of navigation to avoid a too large craniotomy. And it's the standard of care we have. So the setup of our room, it's just an illustrative image. So we can now see the dural opening. We can see the around the lesion. We can see, we can inspect the adjacent dura mater. And I think it's a very simple surgery in this case. So there's not, it's not so challenging. And so our responsibility is to avoid any residual, any fluorescent spots, as you can see here. There are lots of arachnoidal small spots. So we remove it all to have a 5'ALA free removal. You can see that there are a lot of small details, and we still not know, we don't have the enough follow-up of these patients to confirm it's necessary, but we should study this. Skip a little more. A final, you can see a final 5'ALA inspection. And we can see the postoperative MRI. So the next case, the next illustrative case is a harder one. So a cerebellopontine angiomeningoma, a large tumor. Cranial nerves are displaced from the midline. We perform a retrosigmoid approach. And after, let me show the video. Okay, after dural opening, we can see this positive fluorescence and a large mass. So the base is coagulated. The booking was performed. So we have the cranial nerves identification, the facial, the 7-8 cranial nerves. So there was aid of the electrophysiological monitoring to avoid neurosurgical impairment. We can see the nerves, the trigeminal. And after the tumor removal, the mass removal, we can see the perostosis are in the petrous bone before the suprameatal tubercle. So bone drilling was performed. And we have a final status of a 5'ALA free removal. Okay. So now we can speculate some answers for why and when. Fluorescence imaging may help us more accurately determine whether excision margins are free of tumor cells. In this recent retrospective cohort study of, you can see below, of 191 cases, visible 5'ALA fluorescence is characterized by a high positive predictive value, detecting tumor bulk and peritumoral tissue in intracranial meningiomas. Although 5'ALA induces fluorescence lacks sufficient reliability regarding specificity and histopathological accuracy to establish consistent real-time assistance in meningioma surgery, in a practical point of view, it seems a promising approach for detection of residual meningioma cells. So I think answering our first question, in our opinion, a 5'ALA assisted tumor resection should be protocoled and considered for all patients with primary and recurrent meningioma. A close and detailed follow-up is needed. It's very important also considering the complete patient history and previous medical treatment, especially radiation, as we saw before in the papers and even in our illustrative case. So why use research and systematic analysis and for future perspectives of maybe an updated Simpson classification? So when used, I think we can focus on our second questions when in intraoperative details such as venous sinus infiltration, especially superior sagittal sinus, transverse sigmoid sinus, foraminal and bone infiltration, especially olfactory groove, as we saw in that case. There's sphenoid wing, a lateral sphenoid wing, or even medial sphenoid wing meningiomas, where infiltration of cavernous sinus and petroclival tumors, very challenging disease, and the involvement of cranial nerves, arteries, and brain filtration are also extremely relevant. So we could eventually prove that a supposed Simpson grade 2 or even a grade 3 removal with a 5'ALA free resection may have a similar outcome to a Simpson grade 1. And I think that's possibly the question. If we can have a Simpson classification of grade 2 or even grade 3, and with this kind of resection aided by 5'ALA, we can have a similar outcome of a Simpson grade 1. So that's an interesting point for further studies, a modification for this classification based on 5'ALA resection. So my conclusions, finally, we can conclude that 5'ALA serves as additional information upon surgeon's experience. That's very, very relevant, and his or her tactile and visual perception. It may be of no value for small convex meningioma. Well, we still not know, but it's still not the standard of care. But we can be an interesting and decisive guide for a tumor partially invading a venous sinus, for example, as you saw in that case. The principle of fluorescence as a real-time method to assist the surgeon in achieving complete resection. And when we talk in meningioma, we can think and cure the patient of benign intracranial tumors, very appealing. So it's a disease, a kind of tumor we can often cure the patient. It enables intraoperative visualization of most important intracranial meningiomas and allows identification of residual tumor tissue at specific sites. So the detection of residual tumor tissue might in future reduce the risk of recurrence. So that's the question. So, okay, I think that's it. Again, I'd like to thank Dr. Raja and all of you and you all for the attention. These pictures you can see upper left, me and Dr. Stummer. In 2017, 2018 at our institution, and now our annual glioma symposium. And in the other picture, you can see Dr. Hamina, our chief, our leader, our father. I'm working at Inc. since 2004, where I did all my resident training and neurological post-graduation. Very proud of being a coordinator of the neurological division. So thank you very much.
So thank you. Thank you very much for the very nice presentation. And we have here a question from Japan, from Dr. Takashi Kon from Tokyo, Japan. He said, I appreciate your informative presentation. We use 5'ALA for brain tumor removal and evaluate, but in Japan, health insurance does not cover all brain tumors, glioblastoma only. And I would like to know whether 5'ALA fluorescence reflect malignancy and some relationship between molecular feature of the tumor other than mitotic index. So maybe you can.
Okay, of
answer.
course. Thanks, Dr. Takashi, for your question. It's a very important question. So in Brazil, we either the WIT insurance does not cover. So the patient he pays about I can make the calculation in dollars. It's about I think $100 for the 5'ALA for the surgery. Okay. So it's not so high. They usually can afford even for high-grade gliomas. So as an institution, we can use it often. We can almost all patients we can use the 5'ALA, and it does not reflect malignancy. Okay. We didn't understand this very well. So we think in 5'ALA as a quantity of cells. So we see malignant cells as high-grade gliomas, about 50 to 70% of brain metastases, especially adenocarcinomas. We can see about, but for example, we can see a medulloblastoma have a positive fluorescence. We can see in contradiction, we can see about 50% of the pilocytic astrocytoma have with a positive fluorescence. About 25 to 30% of the grade 2 astrocytomas have a positive. Same. And it's very important to notice in the gliomas anaplastic spots we can see in the fluorescence. So it doesn't have no relation with malignant. But we can see in gliomas, a mitotic index, such as MIB1, they may have some relation, but other markers as, for example, IDH or MGMT doesn't have, and we still don't understood this. But we're improving. For the years, we're improving. We have a lot of experimental studies in vitro trying to have the real marker, or the real markers for this kind of response.
Yeah, thank you. Yeah, thank you. I'm also very interested in those subjects, so I keep studying. Thank you. I read your paper and study more. Thank you.
Okay.
Thank you. So, are there other questions?
May I ask 2 questions, Professor?
Yes.
Yeah, actually in my country, the 5'ALA is quite expensive. I think about 2,000 USD in my country. So we really spare for only cases we suspected high-grade glioma, not even low-grade glioma. My question, Professor, you did show us there's some fluorescence on the arachnoid itself, because in symptom classification, we only talk about removal of tumor dura, and we didn't go to the extent of removal of arachnoid. So do you think that the removal of arachnoid, I know you have mentioned that you do not have data on it, you do not have follow-up on patient that you remove those arachnoid. So do you think it will be relevant in the near future, especially those with a higher grade of meningioma? My second question, Professor, because we do have a cheaper version, we call it fluorescein, and there are some researchers that use both fluorescein and 5'ALA. So do you have any experience using the cheaper version, the fluorescein? Thank you, Professor.
Thanks, Dr. Boon. So about the questions first, fluorescein we're using at our institution just for vascular neurosurgery. So I don't have any experience, just with 5'ALA. We see a lot of papers working of the two together, but it doesn't seem to aid in synergy. I think 5'ALA is very effective especially for gliomas. So we have this tool, it's like a hammer. So we try to use the hammer in everything like nails. So I think we still improving, because we still don't know. We need to research, especially with prospective studies, with a lot of clinical investigation, in vitro investigation. We still don't know what kind of cells have a positive fluorescence. So high-grade gliomas is very important. If we can aid another dyers, another currents in the surgery, it's very interesting too. But I don't think the fluorescein together with 5'ALA can be relevant for meningiomas. So the first question, sorry, pardon, I didn't understand well.
The removal of arachnoid that you show with the
removal. Yes, I show at the second surgery. So the question is it necessary? Is it necessary? We still don't know. We should always remember at the Simpson classification about 50 years ago, without microscopy, without surgical microscopy, we have a recurrence rate of about less than 10%. It was a very small. So we should study these patients where we have a PL, arachnoid removal of that small red spots through the years, and compare with the patients treated with the standard of care of surgery without a 5'ALA. So it can help to avoid a recurrence. Possibly, yes. In the practical view, we want to believe it's important, but I don't think it's relevant now. For now, but it's very different for. I think it's very different in complex cases where we have a infiltration of vessels, of cranial nerves, of even the bone with bone spots, and if we can avoid, for example, where when we cannot remove all the dura involved. If we can just coagulate and remove that small spots in a infiltrating lesion or larger lesion with infiltration of surrounding areas, if we can have a Simpson 2 or Simpson 3 classification with a 5'ALA free removal, if we can consider this in the future as a Simpson 1 with the same result, with the same tax of rate of recurrence. So I think that's an important question we should study. So it's for further studies, surely. And I think we will have this answer about in a few years, surely.
Thank you,
so
Professor.
maybe I can say a few words regarding fluorescence and 5'ALA fluorescence. Because I was study both and also through my over 10 years experience with confocal microscopy, you are working on a cellular level. So the big difference is that 5'ALA is working intracellular, and fluorescence is working extracellular. So what it means? This means that if you give fluorescence, it's not able to go into the cell. Yeah. So you don't have a focused fluorescence in one part of the brain. So if you start then working with this, because I did hundreds of tumors with fluorescein and also with 5'ALA, thousands of tumors, because we have it here in Germany since 2005. And also working with ICG and tumor as a third fluorescence marker. I can say fluorescence is the most deadly, because as soon as you start to open vessels, and if you are operating tumors, you immediately open vessels, then it goes everywhere, and you have a flash everywhere. You have also a flash over the normal tissue. Yeah. So I did also in my career a few totally crazy things. I combine everything because I was working a lot with microscopists companies. So we develop microscopes here in my department, and during these developments we use, for example, 3 fluorescence markers. All these 3 what are approved for neurosurgery, and we change in the channels in one and the same tumor. So I use, for example, for glioma, all the three, and I change in the same session, in the same surgery. I change from the one channel to the other. And so we create a profile, what is the best for which kind of tumor. And so fluorescein was in I would say approximately in no one a good marker. 5'ALA, I think we will found in the future for sure correlations between the mitotic and the mitosis of the tumors and the brightness of the fluorescence. We will for sure found correlations in this. Because we did here also the following thing. We gave 5-ALA 1 or 2 days before surgery for grade 1 and grade 2. And we saw in a lot of grade 2 tumors fluorescence. So I cannot, I don't have another translation of this effect. Yeah, I think that for the high gliomas, for the high grade gliomas, the metabolism is very high. In the low, the metabolism is very low. So I think for this metabolization, 5-ALA in the low grade gliomas, it needs more time. And I think this could be a way to go in studies, yeah, to see if the time when you have to give the 5-ALA, it makes it makes a difference or it plays a role. And but regarding fluorescence, I can say no way for neurosurgery. And regarding vascular surgery and vascular neurosurgery, because I did also in this way a lot of studies with different fluorescences. I can say that fluorescence is from that point in comparison with ICG much worse, because it stays and it goes and stays in plaques, in arteriosclerotic plaques. So if you give it before you clip and if you give it after you clip, you have this this fluorescein arteriosclerotic plaques still shining. Yeah. What with ICG you don't have it, and this has also to do with intracellular and extracellular action of the both fluorophores. ICG is going also intracellular, and it starts to shining intracellular, and so I think the combination of studying on a molecular basis what's going on with fluorescences, with the fluorophores in general, it makes sense. But we have also from Professor Teo. Also, yeah. you have also a question?
Yes, please. Yes.
Yeah.
So with regards to a couple of comments. So one is about the arachnoid resection, you know, that little tiny nodules of arachnoid. In that case, patient previously had radiotherapy. So we know radiotherapy-induced meningioma is not going to be focused to that particular spot. So I would say the chance of recurrence is very high in that case, whether we remove that little tiny nodule or not. I guess the answer would be more to do with the genetics, isn't it? Because we know like Priscilla works with the genetics of meningiomas in Harvard. And I know there's different groups, like some of them with SMO mutation and AKT1 and NF2. So they all have been shown to relate with the growth of tumor, even though they're all grade 1 tumor. So I guess maybe that's where you go for trying to get rid of tumor recurrent in the longer term for this sort of secondary meningioma. For the question about when you remove meningioma, do you have to remove tumor from the arachnoid? If you see it, like we don't use ALA, but if we see it, we remove it because it makes sense. Because if you think about it, the origin of it comes from the arachnoid capsule. So it's not necessarily from the dura itself, right? So, but yes, we do not, if we don't use ALA, we might not see a tiny little nodule and we might have left it behind. But I doubt it will make a difference to the recurrence.
Yeah. I think for meningioma, it makes a sense to see the duratel, you know, so how far is going after you remove the big part, yeah, on the sides, on this asterion sides, no, and this satellite. And I think this is a good application. This is a good thing to see it.
So it's very important we have the intraoperative pathology, the frozen, to compare the 5'ALA response with the, we do this often. So, and we still don't know what Dr. Mario said before. It's very important. So we have a patient with a radiation, and we even in patients with high-grade gliomas, if we have a subependymal, positive subependymal captation, fluorescence positive, and it doesn't mean that they have a local infiltration. So it's a very controversial response.
Yeah. Okay. So are there more questions?
Okay, thank you, Erasmo. I have a small question. Do you think it's helpful if you removing a meningioma already invading in the saphenous sinus surrounding the ICA? So is it helpful to detect the ICA when you use this Fluorescence?
Yes, we can possibly detect. So we can see, even in the videos, we can see a very distinct difference. In the case of extraxial tumors, I think it's a safe, it's addictive for the surgery. So we can have a very good distinction between the nerve, between the vessels, so even the sinus. But we can't have a total, we can't expect just these two. It's not necessary, it's not sufficient. So there's a lot of others factors involved in even electrophysiological monitoring, even navigation. So, but for meningiomas, I think it's a tool that will aid the surgeon in the decision, and you can see often the difference, and we can see the nerves in blue or even in red, in blue or even in green, or even the nerves in blue too. So we can expect a safer removal. But we still don't have an exact question. It's I think it's a tool, and as a neurosurgical tool, it's here to be used with a very good systematization, a very good methodology.
Thank you, Professor Erasmus. Thank you, Professor Cleopatra, and all the distinguished panelists. Now we probably go to the end of the session. May we hear the concluding remark from Professor Cleopatra? Professor.
Yeah, thank you. Thank you for the very nice ACNS webinar once again. I hope you continue. And thank you all the participants. And have a nice day wherever you are in the world.
Stay safe,
Okay,
everyone.
thank you.
I'm
Thanks
very
for
honored
the
to
Thank
be
you.
with you
Thank you for
today.
your
Thank you.
very
Thank
nice
you.
presentation.
all.
And
Thank
tonight
you.
we have 1,417 audience in the WeChat channel. That's a great
okay,
number. Yeah.
Thank you
Okay.
very much.
Thank you. Thank you.
Okay,
Thank you, sir.
bye-bye.
Bye-bye.